about a clinic imaging marker in ischemic stroke. Um, so we all know that stroke is the leading cause of acquired disability and second most cause of death in the world. Unfortunately, in the Middle region, new including Pakistan, has reached around about 5 years, and most of the more than 60% of the patients are below 50 years of age. That's lead to premature disability. The risk factors are the same: the diabetes, hypertension, smoking, obesity, and metabolic syndrome. So the current treatment that we have are the CT scan and MRI to check the damage which has been achieved to stroke. The imaging markers are the in MR. They are the silent forms, microbleeds, white blood, white matter in hyperintensities. So our concern has been that these CT scan and magnetic resonance imaging cannot be performed to detect the early, even pre-stroke neuronal damage. So we were interested to something that we can detect pre-stroke neuronal damage. For that purpose, most of the studies that have been done in relationship with the eye and the stroke have been focused on the retinal vessels, blockages, or retinal nerve fiber defects and optic nerve. But we are going to work on cornea. So the cornea is the anterior part of the eye. It's a fascinating part, and we're going to look at the corneal nerves. These are the nerves which we have pioneered this technique manage these nerves in different neuropathies, and we're working for the last. My team has been working for the last 2 decades. Before it was started in diabetic neuropathies, then after 2015 we started in neurodegenerative conditions. So the human cornea consists of 5 layers: this epithelium, bounds layers, stroma, descendants, membrane, and endothelium. So the nerves are in the subbasal layers at the bounds layer. So we can image them with through using the in vitro photochemical microscopy. I'm going to tell them about later. These are the action of the nerves. In the superior and middle side, we make it 600 times bigger. So they enter from informing from corneal limbus. They are thicker in the beginning, then they move forward, so they become thinner and give rise to mid-stromal axis. So since the last 3 days I have only listening about the scanning stuff, all the intervention and needles, but what we are looking about this technique is that it's not invasive. It is easily can be done, and you can capture a lot of nerves within 10-15 minutes. That gives you a good amount of data to decide the neuronal damage. So this is the techniques where I'm going to examine the patients. You can see the corneals there, and you can, in the next image, is the corneal nerves. The white lines are the nerves. Along with them, there are some dendritic cells as well, immune cells. And the next image is about how we analyze these corneal nerve parameters. So there are 3 parameters that we are going to measure in that. One is the length of the nerve. This, for example, is we see the red light, and branches it come out from the main fibers, the red lines. So those are the branches, and all the nerves in a single image of corneal nerve fiber density. So we got three parameters: corneal fiber length, corneal fiber density and corneal fiber branches. So this looks like in the artifacts of corneal nerves, and they are coming from the periphery of the corneal spinal nerves. Okay, so they're going to one point. They're going to exit at nasal inferior side. They make for their hole, and usually like if the patient is ready, so in just 3 minutes you can have like 100, 200 images later enough to make a decision on that. So when you are going to use confocal microscopy, so we are going to move forward. So we are going to see these layers. The first is the epithelium. So the next is like nerves, and then stoma, and then endothelium. So yeah. So the technique was, as I mentioned, it was used first for the diabetic neuropathies. And in the first image we can see with neuropathy there, it's a little bit when you're going to take the mosaics, the whole corneal image, you're going to cover the whole cornea, and the whole image is, so you need to maintain a mosaic. So it's a little bit, there are some compression here. But the first one is with the neuropathy, and the other one is without neuropathy. Sometimes you can see some of the pages where the nerves are lost over there. So what was the objective of the doing corneal confocal microscopy in the store? So the main thing was that we want to see the quantify the corneal nerves and the pre-stroke neuronal damage, and to compare that pre-stroke damage with the outcomes, and to establish the relationship between corneal nerves and the risk factors for the stroke. So I was planning to move from Australia to Eastern US for now, and then Professor Ashfaq, I never knew about him before this. He was moving to Doha, Qatar, and there was a guy, Professor Yas Malik. He's done extensive work on proposed microscopy along with our team in Brisbane, in Australia. So these two giants were coming to Qatar to work, and I was thinking to stay for a very little while for their corner, but they forced me to stay longer, and we are going to start stroke. So for example, they have already started going to start stroke according to focal microscopy. So this is the place they need properly. So you can see that's how we started. You can see on the right side, Professor Mahir over there. It was very busy clinic, and it was very sensitive stuff that we first will start. So like that. The patient is over there with the OCT basically. I will talk about that as well. So I think he is confused where I am because he has got larger conclusion of the factor line. And yeah. But my profs, Professor Malik and Professor Shweb, they were driving in safaris. So they had over everything to me and Professor Malik to work out. Okay, so the first study that we did it, we looked at first scanning stroke patients. There were over 146 stroke patients and 18 controls. So the clinical parameters were higher in the stroke patients as compared to the control one. So what we found, that irrespective of their glucose levels, there was neuronal damage in the sense of corneal damage. It was over there. So we published that in the stroke in 2017. You can see the first image is about the healthy control one. The second one is the stroke patients with normal glycemia. And the C is about the impaired glucose patients. And the last one, the diabetic one, and more severe neural damage is the renal. So the result showed similar results in the graph forms. Okay, we can see the green bar has the highest neural resource and as compared to the other green one. And it's a corneal fiber density. All the parameters will lower in the stroke patients, irrespective of the disease, the C and the corneal branches, as well as the length of the nerves. We looked at the association. We found the association with the triglycerides, HbA1c, and BMI except the branches. The BMI were not related with the branches. That is somehow the nerve fiber density was going to be associated. Okay, so next thing we were going to do was, is there any relationship with the inflammatory markers? So we did the study and looked at the corneals and with the inflammatory markers and look at TIA patient as well as the stroke. So we want to look at whether there is a difference between TIA and the stroke patients, neural damage. So there was difference, there were more neural damage in the TIA patient as compared to healthy control. There were in stroke, it's already established that there was damage more than control. We look at the inflammatory markers. In inflammatory marker, IL-6 was higher in the stroke patients as compared to the TIA and E17. The rest was comparable. Just need to go quickly. The corneal parameters were correlated with the IL-6, but they were not correlated with the other parameters. So it has been already been shown in the eye. The nerves are related with the IL-6 and positively. The next thing we were going to do, we were going to compare whether the neural damage in the brain is related with the corneal nerves. So we saw that we found that white patients with white matter intensities, they were more damaged in terms of corneal fiber density as compared to without white matter fiber intensities. It's a figure. I'm going to go over to the graphs, the right lower one. So you can see what the average COP, the COP was lower in the patients with white fiber intensities compared to the non. Next thing that you will do, whether the patients with the second stroke, they got one stroke and after some time they got another stroke, whether there was some difference between their neuronal results. So we found that the patients with the second stroke were having more corneal damage than the patients with the first stroke. We can see in the graph is the skin if you look at corneal fiber density and corneal fiber length, so they were the corneal fiber density was lower, much lower in second stroke as compared to the first stroke, and the other parameters were comparable. The other most important bit when you're going to develop the imaging markers or the biomarkers, so you need to look at whether whether the technique is going to detect the changes as well. So we look at the vascular factors in the longitudinal study. We look at the patients first at the baseline and after a year, and we're going to look whether these vascular factors are going to improve the neuronal results. So we did this in 56 control and 81 in TIA and stroke patients. So if you look at the bottom, along with the improvement of the vascular factors, we got the improvement in the neural results as well. So we see the treatment is going to come up very soon. So the next thing that Professor Shrey was very interested, and it is his name, biocollaterals. So he wanted to whether the patients with those who get poor collaterals have more neural damage than the whether as compared to the good collateral. So we look at the patients with the good collaterals and with the bad collaterals. So in the figure 8, you can see the health control, the B with the moderate and good collaterals, and the C with the poor collaterals. So we can see the difference that it's more neural damage to the patient with the poor collaterals. And we can see the damage, the neural damage to the different collateral status. So we were interested whether these parameters are able to differentiate between the poor and good collateral patients. So what we found is if we look at the nerve fiber length and the branches, so it's going to help us 72%, the length, and the branches are going to help us 71%. So we can differentiate it. This is the retinal part which most people has done. There is a first study that showed that retinal matrix are correlated with the fibroblastic cells. But that was done by James Weber in mice. So we want to translate that findings. So we got like 21 control patients with the 35 established and I won't appreciate Professor Mali has helped me a lot in that. So we got the OCT of the patients where we can see in the right side the retinal vessels, and we got the longitudinal patients, and we classified the retinal matrix in different dimensions. So the multi-fracture damage, these parameters are very important. It has been established in the literature that retinal fractures are associated with some strokes and different kinds of strokes. But it was not established in the longitudinal occlusion patients. So this we found these findings, so we published them, and we found that the fracture is the information about the retinal vessels are higher in poor collaterals as compared to the good collaterals. We can see the D0, D1. And this, when we did machine learning to separate the retinal matrix of poor collateral and good collateral of the patients, so it told us about like 75% patients can be differentiated between poor and good collaterals by using retinal matrix. Yeah, so yeah, they are there. So the conclusion is that we found it is neuronal pathology in patients with acute ischemic stroke, and this represents the protective risk factors who are connected to those damage. And we are proposing like corneal nerve fiber predictive index, so that like we can triage the patients with the GIA, stroke, and in the recurrent stroke. We are going to analyze the data about the corneal nerves damage and